Welcome to MenopauseWize, your go-to podcast for all things evidence-based in the menopauseverse. I am Dr. Supreet Patel, an MD gynecologist, a menopause health advocate, a postmenopausal woman, and the founder of MenopauseWize. And I'm so excited to have you join us on this journey. Whether you're a healthcare provider looking to stay on top of the latest evidence-based practices, a woman navigating your own perimenopause or menopause journey, or a partner or family member eager to support a loved one, this series is designed with you in mind. Our mission through MenopauseWize is to close the menopause knowledge gap by bringing you the latest research, expert insights, and practical advice, empowering you to make informed decisions about menopause and perimenopause. Welcome to today's episode of the MenopauseWize podcast. Joining us today is Dr. Roshani Sanghani. Oh, goodness. No wonder.
What?
I'm sorry. My audio is not connected. We will restart.
Okay.
Sorry about that. Okay. All right. Welcome to today's episode of the MenopauseWize podcast. Joining us today is Dr. Roshani Sanghani. Dr. Sanghani is an American Board-Certified Endocrinologist, the author of Turnaround Diabetes, and has been a certified diabetes educator and trainer. In fact, Dr. Sanghani will be launching an online course on nutrition for diabetes next month, that is June of 2025, a much needed initiative aimed at empowering individuals with the tools to prevent and reverse metabolic disease through evidence-based accessible strategies. I'm very looking forward to exploring that one. So Dr. Sanghani, welcome to the MenopauseWize podcast, and thank you for joining us here today. Absolutely thrilled to have you here.
Thanks for the work you're doing.
Well, we need an army, and so thank you for being there. Let's just dive into today's conversation. A very overlooked area when it comes to menopause, because we don't usually connect the dots, is diabetes, insulin resistance, and menopause. And we know now with the hormonal shifts at perimenopause that there is a change in our insulin sensitivity, in our blood sugars, our tendency to develop diabetes and metabolic disease. So could you tell us, as an endocrinologist, what is really going on in our body between all these hormones at that time?
Yeah, so thanks for that question. And in my book that came out last year, Turnaround Diabetes, I put a section on women's health. And there's a dedicated comment there about perimenopause, menopause, because classically we think that women have less risk of heart disease than men, but that only holds true till menopause. And post-menopause, as female hormones are on the decline, the estrogen and the progesterone, women start to develop the same kind of risk factors as men. And to give sort of like a oversimplification of what happens to fat distribution for women versus men, we were taught in medical school this concept of a pear-shaped versus an apple-shaped distribution of fat, where women tend to have the curves on the hips and the men tend to have the curves on the belly. And that very oversimplification can be true till menopause, after which, as the woman has lost the estrogen and progesterone, she'll notice more tendency to gain weight around the belly that she may not have had in her own life, the first so many decades. Suddenly she's finding difficulty getting that belly fat off, or just new onset of fat accumulation around the waist that she never had. Now, this becomes important. You may not have huge amounts of weight gain, but it's this key zone around the waist, which we call belly fat or visceral fat, which as an endocrinologist, we care about it. And of course, as a gynecologist, you care about it. This becomes a indirect marker of cardiac risk, indirect marker of diabetes risk, where it's interfering with how insulin hormone should work. So it becomes like all hormones are integrated, and we spoke about this before the podcast went live, is yes, estrogen, progesterone, but female hormones affect the entire body. They don't just affect female anatomy. They affect everything, our mood, our brain, our sleep, our memory, skin, muscle, bone, everything, appetite, fat, insulin. So I could go on and on, but there are so many ways that the two things are connected.
Of course, and you mentioned the pear-shaped versus the different shapes of the body. And if you could, for our listeners, spend a little bit of time on the waist-hip ratio and how one can just use this at home.
Yes. So you don't want to have a waist hip ratio that is higher. So the lower the waist hip ratio means that you've got a narrower waist and more fat distribution on the hips, which tends to be a safer place. Now, offhand, I'm thinking it's 0.8 that we use as the cutoff. And, for me, by the time people see me, they've already accumulated a waist hip ratio that's much more than that, where you ask them to measure at the largest point around the waist and at the largest point around the hip or the buttock area, wherever is the maximum fat distribution. And you're looking for the waist to be narrower than the hips. There's some argument that instead of BMI or body mass index, we should be using something like a body fatness index, because BMI, if I use my own example, before I was exercising, my weight was a constant 54 kilos. And after I became regular with strength training, I gained 4 kilos. So on BMI grounds, maybe my BMI got worse, but I know that the 4 kilo weight gain was all muscle, lean muscle tissue. So percentage-wise, my fatness has gone down, my leanness has gone up. So the BMI would throw you off and you think there's something going wrong with this person. So body fatness index takes into account numbers like the waist hip ratio, where you're looking at what is the percentage of body fat.
Right. And I think I've heard recently about something called body roundness index as well.
Yeah, similar.
I haven't read too much, but yeah, okay.
It's the same concept.
And yeah, and I guess like a lot of us sort of get entangled in the whole weight number, and the body composition becomes such an important part, like you mentioned. Similarly, I think I've been the heaviest I've ever been in my entire life in the non-pregnant state, but it is working towards gaining muscle rather than looking at fat. So yeah, body composition, such an important thing to look at. So what happens, you've explained what really happens, during perimenopause. Now, if we look at symptoms, am I going to know that my blood sugars are high? Will I have any symptoms, or how does one get to know?
No, in fact, I would call this a silent epidemic. And if your audience tends to be more on the ethnic side, we want women to be getting screened early rather than be waiting for this to sort of come as a surprise. So anybody who has gone into the perimenopause phase, we don't want them waiting for it to show up with symptoms. By the time diabetes or prediabetes comes in with symptoms, it's probably been lurking there for at least a few years. So you want to catch this before it develops, which would be your own just basic annual checkup and HbA1c. Even on a lipid panel, a basic lipid panel, we can see insulin resistance in the triglyceride HDL ratio.
Right. So what should the triglyceride HDL ratio be? That's what's a healthy ratio to have?
Yeah, so again, I use the same logic as the waist hip ratios. You want the waist number to be less than the hip number. I like to keep it simple and not get too much into memorizing things.
Yeah.
Similarly, you want the triglycerides to be less than the HDL. So the ratio needs to be less than 1. Once you get it to be higher than 1, where the triglycerides are more than the HDL, you're starting to creep towards it. Now, the papers and publications say that the triglyceride HDL ratio more than 3 correlates with cardiac risk. But the minute you're in the 1 range or the 2 range, I'm already monitoring this. Yeah. I'm like, hey, there's a trend here. We want to catch the trend.
Yeah, makes sense. Yeah, it's about it's about wellness and not sickness anymore. So catching it early. So coming to tests now, what are the tests? We've heard of blood sugars, we've heard of HbA1c or glycosylated hemoglobin, and now you mentioned triglyceride HDL. What is it that I should test myself for? Let's say I'm perimenopausal, my cycles are beginning to get a little off, or I'm postmenopausal and 12 months down the road. What should I be screening myself for, and how regularly should I be testing myself?
Yeah, so again, you're in Canada, I'm in India. We have different access points to getting tests done. I know that I work with some people internationally, and sometimes they're restricted by what their PCP will order. So I'm going to tell you what I look for, because sometimes guidelines or local policies may stop us from ordering everything we would like to. But things that I look for is most of the times people are going and getting, in India at least, an easy sort of checkup, right? A health package. And they'll be looking at things like the lipid panel. I look at the liver enzymes on a normal liver panel. Again, you don't need to screen everybody for liver disease. So walking, talking people don't need to go and get their liver tested. There's really no need for it. But if it shows up and I'm looking at it, I'm looking for SGOT to SGPT. And you want to see that these, I like to see the SGOT or SGPT, which is also in the West, they call it AST and ALT.
AST and ALT.
I wanted these to be less than 25. I'm finding that what used to be less than 20 when we were in training, now the labs are tolerating 20 plus, they're tolerating 30, they're even saying up to 40 is normal.
Yeah.
I think there's been a sort of baseline creep where the whole population is getting more and more fatty liver, non-alcoholic fatty liver disease. So that's another invisible marker of insulin resistance sitting in the liver, which is your organ, and it is in charge of trying to prevent insulin resistance. So your liver tests will start to show you that, oh, there's too much carbohydrate, too much fructose, you're getting fatty liver, and one of the early signs can be liver enzymes going up. So that's one more that you might catch on a routine panel. Of course, we talked about the triglyceride HDL ratio, the HbA1c, we want that to be less than 5.7. Now, even here, you can see a creep where it used to be 5, then 5.2, then 5.5, 5.7, and sometimes the doctor will say, oh, it's on the border. And one of my patients was like, hers was 6.4, and the doctor said, oh, you're fine. She came and asked me that, why did he say it's fine? I said, you have to understand, in the doctor's office, when they're overwhelmed and they've got long waits and long patient, waiting areas and appointments are full, you don't look like a crisis right now. So you're not sick enough to get my attention. So a 6.4, yeah, we don't need to act on you yet, right? But in the preventive space or in the wellness space, we're trying to see proactively instead of reactively that this is a trend. It's about to jump over the fence into the diabetes zone. So the process has already started. So hemoglobin A1C, fasting glucose, we want that to stay less than 100. But if you scan back your reports and you see, most women who are in perimenopause, if they've ever been in the healthcare setting, they've probably had a fasting glucose done at some point. So track that over time. Now's the time to pull those old records out. Did it go from 80 to 90 to 95? Are you creeping up on the fasting glucose? So these are some easy ones. You don't have to spend extra money. I don't believe in asking you to just keep on getting tests. I think sometimes we over-test and there's enough things we have in our hands to start working on in terms of lifestyle change. So I like to focus my energy on that.
Makes sense. Makes sense. What about the home glucometers? They're easily accessible. Are they any good for just screening?
They are. You wouldn't use it to make a full diagnosis, but sure, if you randomly were to prick and if you see a random above 200, that's definitely a warning sign that something's going on and you may not feel it. So we say that impaired fasting glucose would be 100 to 125 and diabetes would be fasting glucose above 126, but you obviously want to confirm that with an actual blood test from a venous sample, not just the capillaries, because these are very, very tiny blood vessels. So you want to get a confirmation on the actual venous blood. But it's a great way to catch something. Some people now are into wellness, they're wearing the CGMs, but again, a CGM is not diagnostic. It may alert you, and I have a tendency for prediabetes myself. About a decade ago, I was in proper pre-diabetes. And even now, if I wear a CGM and I have my favorite Gujarati desserts like a puran puri, mango, it's mango season in India right now. So amras, puran puri, I'll spike. So the numbers over here will just be very alarming. And then I confirm it with the glucometer. So I can tell that I have impaired glucose tolerance. So yes, home monitoring is a great low-cost way to check.
Wonderful. So even if I do screen, you said fasting, so fasting would be typically 10 to 12 hours would be what is standard, right? Okay. Coming to role of lifestyle, because type 2 diabetes, it's amazing how much information we have out there about it's preventive, it's preventable, it's something that is a lifestyle illness. It's been declared. It's been like people are yelling out about it, and still we are seeing some increase in numbers when it comes to diabetes and poor metabolic health. So if you can just simply, of course, lifestyle is such a broad term, but for our audience, if you can explain it in a simple way and then tell us different things that we can do to prevent and manage diabetes. Yeah.
Yeah, and I'll try and put it in context of your focus area, right? Is perimenopause, menopause. Uh, Especially the woman. I mean, the woman tends to sometimes be the central person in home, even if she's working, right? I mean, I'm not saying anything about roles in society. I have some strong opinions, and I have a chapter on patriarchy in my book also. Because I have two young daughters, so we want to prepare our girls to, have as many opportunities as they can in life. And yet this sort of childbearing thing comes to women, and then the aftermath of that. So perimenopause and lifestyle, what shall we say about that? So in my approach to helping people take this in their hands and actually turn things around, that's why I call the book Turn Around Diabetes. I talk about a car with four wheels. And the four wheels in order of importance are nutrition, sleep, stress management, exercise, in that order. And we were talking about this, right? Is four pillars, or I used to say four legs of the table. That was my journey with creating an analogy that I could stick with. And I stuck with four wheels of the car. And the reason I did that was because life is never the same. Life keeps evolving. The scenery around you keeps changing. Events in life, challenges, always throwing new hurdles in our path, right? It's a dynamic journey on life. And you could have a flat tire in one wheel and it could stop you in the middle of the road. It doesn't have to be all four wheels, or it might be that all four wheels are affected. So in perimenopause specifically, what happens is your insulin resistance tendency goes up, which means what? Insulin is the hormone that is connected to diabetes, obviously. Here we're talking about type 2 diabetes, where even though you have insulin, and the job of insulin, let's make it very simple so even a 10-year-old listening can understand. The job of insulin, which is a hormone, is to take the carbohydrates, or actually all nutrients, and put them inside the cell. Even if protein is consumed or even if fat is consumed, to a lesser degree, insulin will be released, and the signal, so hormones cause signaling. They send instructions, messages. We talk about hormone, we say hormones, but what are hormones? Hormones move through the entire body to send messages to each and every cell. They're delivered in the bloodstream to every corner of the body, right? So insulin reaches every cell and says, store fuel, store fat, do not burn it. And the problem comes when you have insulin resistance, where the cells are not able to really get the message about store fat, store fat. So insulin has to work harder. So body is secreting more insulin to get the same job done, because it's almost like if you have someone in the family who's hard of hearing, you have to talk louder so that they can hear you, so the message would reach. So insulin gets a bit louder, or the levels go up, so that the glucose or the fuel will go inside the cells. Now, this starts to become more problematic in perimenopause because she's lost the estrogen and progesterone. So now insulin actually loses some of the hormonal support that would make insulin do its job effectively. So her nutrition may have been the same, but now it's starting to catch up with her, right? And she'll be like, but I ate like this my whole life. So again, here, carbohydrates being the one food group that raises insulin the most. And this would be your fruits, your sweet things, sugar, of course, juices, and non-sweet things, which are your breads, cereals, pastas, potatoes, starch, any kind of starch, anything that comes from grains, even millets, even lotus seeds, right? So makhanas, pop nuts, popcorn, all of this comes under grains. So these would all be carbohydrates. Those become your low-hanging fruit. To cut those down, replace them with protein. That would be lifestyle change number one, is nutrition.
Wonderful. Wonderful. And then you said the next one was sleep.
So
and nutrition and sleep. Sorry, go ahead.
Yeah, so now it starts to accumulate, right? So when we go through perimenopause, sleep becomes an issue, where loss of estrogen specifically And you'll have difficulty falling asleep, difficulty staying asleep. We classically hear about the, very famous hot flashes that wake you up in the night or in the middle of a meeting or in the air-conditioned room, you're bursting into sweat. What is that? Your blood vessels are what we call unstable, vasomotor instability. So you suddenly have these blood vessels dilating and creating this huge flush, and you're breaking out into a sweat as though you've just come from running on a treadmill. But you were just resting, right? So it's very disturbing, very distressful. It can happen in the night. You wake up in drench like sweat. And this is going to ruin your sleep quality. Now what happens is you've not slept well, you're tired, your brain is not rested, you're getting some brain fog the next day, more cravings, and we all know when we've not slept well, our cravings for junk actually tend to go up because we're looking for that hit, we're looking for that dopamine kick. And the solution could have come if I could have helped my sleep to get better. So this is where sleep hygiene comes into play. Of course, I'm a big fan of bioidentical hormone replacement, which definitely helps to replace the problem in the first place, which is give back the lady her hormones that she's lost out under medical supervision. So, but in absence of the hormones, let's at least work on sleep hygiene, which is, okay, what's happening with your lights, artificial lights after sunset? Right now, I've got this massive LED bulbs shining at me to look glowy in this podcast, but the sky outside is pitch dark. It's black outside. So ideally, what I should be doing is wearing these right now.
Okay. Cool.
Yeah, right? And just for your audience, I mean, these block blue light, right? So if I was to keep this like this and stay like this for a second, then pull it off, you're going to see blue. Yeah. It just flashes before you. And blue tells your brain that it's day outside. And there's this whole fascinating thing about how all of life on planet Earth came from underwater, where there were only two colors. Blue is day, black is night. So all of life is programmed for blue means day. And all these LED lights are more, our mobile phones, our devices, they all emit LED, which has a blue frequency. So that confuses your brain when's bedtime. And then we take melatonin supplements. And it just bugs me that a woman goes to her PCP for insomnia. She might get melatonin. She might get an antidepressant if her mood's off because she's like cranky and just unslept, and the estrogen being low, her mood goes down. And so she's on the sleep aids, she's on the antidepressants, and now she's got some weight gain around the belly, so she's offered the GLP-1 analogs, and it's this polypharmacy going on where each symptom is broken down into one prescription instead of zooming out and saying, oh gosh, this is perimenopause, let's get to the root of the problem, right? Yeah. So sleep and stress management. So loss of estrogen, and I think women make excellent leaders, and I think there would be less war if we had more women in charge of big decision making. I think one of the reasons for that is our hormones help us manage difficult situations. We have this innate ability to build relationships, bring people together. It's part of the way we're wired. And as we lose those hormones, stress management becomes a little more difficult. We feel edgy, we feel cranky. Even in the younger years, some women are very susceptible to PMS, premenstrual, when that beautiful protection on the mood that comes from female hormones declines in those few days before the period. And I know that some of my worst arguments have happened. In hindsight, I'm like, oh, you know what?
What was I thinking?
Premenstrual days. Yeah, I just didn't realize it. And not to use that as an excuse or a weakness, but it's about awareness. Is your hormone patterns do change over life, over the week, over the month, and it helps to know that so you can give yourself that space and find other ways to remain stable and high functioning. So stress management then becomes something we need to use other tools besides the innate gifts that we had of the hormone protection. And when you're having poor nutrition, when you're having poor sleep, the third wheel of stress management can be even more, tricky. Mm. And then exercise, right? And this is something we talked about, is I put exercise purposely as wheel number 4. The catch is when somebody is gaining weight, right? Or difficulty losing weight, what do they normally get told? Eat less, move more. Calories in, calories out. But she's tired. She's not well nourished. She's probably protein deficient. She's not sleeping well. Her mood is off, and how she's supposed to go drag herself to the gym. Like, She's having trouble making decisions, prioritizing, saying no to certain things. All that's gone up in the air. And now she's supposed to suddenly have the bandwidth to exercise. So I don't push exercise on day one. I say, let's fix nutrition first. That'll help your sleep. Actually, so many important amino acids that help sleep and help natural melatonin release would come just by fixing nutrition, right? So nutrition gets better, sleep, gut health, that has a carry forward effect on your stress management. Then you're waking up fresh with more energy, better rested. People themselves say, I'd like to start getting more active. I'd like to start moving because all this extra energy is getting mobilized. So exercise being number 4, but extremely important in perimenopause. Why? Because we know about osteoporosis, right? So what does osteoporosis have to do with menopause? The uterus and the ovaries are down there, but estrogen goes through the entire body and protects you from losing bone. Now, bone loss falls off a cliff. You're losing bone as you go above the age of 35, but you fall off a cliff when you enter into menopause because of the quick loss of estrogen. So we need to compensate against that with the strength training, muscle building, and of course, without the right protein, the workouts are not going to give you those gains. You'll be malnourished, you won't recover, poor recovery, right? A lot of women say, I find it so difficult to recover from the workouts. Check the nutrition, the sleep, the stress management. Exercise to build muscle and bone.
But what about the muscle as an organ for metabolic health? Right, there's more and more evidence that it's supporting our more muscle mass equals less possibility of getting diabetes. Is it a better utilizer of blood glucose?
Absolutely right. So I came across an article that talks about the 3 musketeers of glucose metabolism. So the muscle is the glucose taker. Its job is to take up glucose from the bloodstream. So, and we've all heard this classically in a different way. We all know this. We've heard of grandparents who didn't have diabetes their whole life and they got it as old age diabetes in their 70s and 80s. What is that? Muscle loss. As they lost muscle, age-related sarcopenia or frailty of old age, the biggest thing that's changed is not their diet. It's not like they're suddenly eating junk in their 70s, but they're losing muscle so quickly, they've lost that buffer which used to absorb the glucose, and then they develop diabetes. So muscle is an extremely important buffer zone. You can hold a lot of carbohydrate, glycogen in the muscle. So the more muscle you have, the more insulin sensitive you are. We talked about insulin resistance as the way towards diabetes, type 2 diabetes. Insulin sensitivity can be brought back by building muscle. So the joke or the catch I always tell my patients is, if mango season 2025, you and mango are not on good terms, where you have the mango and it spikes, focus on those lifestyle changes, nutrition, sleep, stress management, building muscle, and maybe by mango season 2026, you'll have enough overall improvement that you'll be able to metabolize that mango in a better way.
Right.
So muscle is the glucose taker. Yes.
And then that brings us back to how body composition is again a better indicator of health than just your weight, right?
For sure.
Because if you've got more fat, then it's not going to manage your blood sugar so well.
Right.
Even if you're less in weight wise, like total mass wise.
So those are the thin fat or the skinny fat, right? Where they look slim, but they have skinny arms and legs, but they've got this little tiny belly going around, and they're still a size small, but they've lost so much muscle that on body fat composition, their body fat is almost 45-55%. More than half of their body weight is fat, even though they look slim frame. So we see a lot of that. Yes.
Now, why should we bother about diabetes at midlife? This day and age, we've got enough glucose-lowering medicines. I remember a relative of mine used to very boldly say, I eat everything and then I just have my diabetes medicine. What is that okay to think, or what is wrong about it?
That's a tough question. So I don't want to tell people what to think. I don't think that's my business. To judge what's right for somebody, right? And I have patients telling me this every now and then. They go through a life patch where they're like, I cannot do the lifestyle changes you're telling me. Please give me a medicine. Now, why did I go to medical school? Why did I put a degree up on the wall? I didn't get into medicine to become a drug prescriber, right? I got into medicine to help my patients achieve health. Now, it's like, do these medicines actually give health? That's the big question. Is, let's say the glucose is high. Many of these medicines don't actually cure the problem. They're curing they're addressing the symptoms of the problem. So like, glucose is high, let's give you something to bring the glucose down. But why is the glucose high? Have you done anything about that? And I like to go to the root of problems. It's almost like an investigative, curious, detective approach that I like to do. I'm not satisfied just being at the surface level, which is why I quit hospital medicine after a while, because I just didn't get any satisfaction out of, oh, they're admitted in hospital, sugar is high, and I'm supposed to come and pump insulin in. And I just didn't feel like I was making a difference in their overall journey. So I said, let me focus on the lifestyle change and try and keep them out of hospital as much as possible. So medicines have a role. It's not like an antibiotic where I have a specific infection, I give you a week of antibiotics and the infection is gone. That's not how diabetes works. If we call it a lifestyle condition, then we're talking about habits that are driving the disease. So what does the pill or the injection do for that? So I end up doing this sort of conversation with my patients is, let me be your doctor if you have decided you want better health with less medicine. If that's not what you want, I'm probably not the right doctor for you, and that's okay. That's totally fine. I just want to sleep well at night, knowing I'm working with somebody who wants to address the drivers of this and the root cause of this. Now, that's not to judge and to withhold treatment. Of course, I had somebody just this morning. We started him on a GLP-1 analog because there's so much going on. He's like, I'm trying to do what you say. There's so many things happening around. I can't cope. Please give me a prescription. Okay, we're not here to withhold treatment and watch people suffer and struggle. He's clearly motivated, but he needs some help.
Yeah. Now that makes sense. And I guess very often in day-to-day medicine, we are using Band-Aids.
Mm-hmm.
Band-Aids on everything. And one fine day the pipe bursts because you've just patched it up so terribly. And again, I want to revisit the term polypharmacy that you mentioned some time ago, and how at perimenopause and menopause that's become such a big problem, because we're looking at prescribing a sedative, as you said, a antidepressant, an antihypertensive, a lipid lowering drug, managing your diabetes, giving her antibiotics for her recurrent UTIs, and the root cause of the problem lies with the hormones, estrogen, progesterone, sometimes testosterone, and very often we're not addressing that, and we're basically doing this patchwork. And you are in a unique position because you are an endocrinologist. We as gynecologists tend to look at things very selectively. But as an endocrinologist, you can see the entire body as a whole. And I think gynecologists need more training in that. We just kind of get stuck to the pelvis and we don't look at the repercussions of that estrogen deprivation on the whole body as a whole. But the whole definition of hormones goes back to produced somewhere, acts somewhere else.
Mm-hmm.
And so if you can, sort of, I know that hormone therapy is extremely controversial. We've done like gazillion podcasts on it, and there's just so much information. But as an endocrinologist, like, you are in a unique position to tell us something about hormone therapy and what it can do to regulate our blood sugars.
Yeah. So first of all, the loss of estrogen and progesterone increases insulin resistance. That's a known fact. So that means increased risk of diabetes, blood pressure, cardiac risk, maybe even some cancers. So we want to replace hormones for those who are symptomatic and who want it, especially in the younger years. And the preferred route I think of is the transdermal estrogen, so that you're not exposing all of the body to what is not required everywhere through the digestive tract, but let it get in through the skin. And that way you're skipping that whole first pass metabolism problem that happens with oral estrogens. And the progesterone to protect the uterus from just constant estrogen exposure, so that you basically have those periods. So that gives a good balance of the protective benefits of the estrogen and then the progesterone helping with the protection from the estrogen. That's the way I look at it. And happy user, happy to say to your audience that about a year and a half now, doing very well on those combinations.
And it does definitely, we have evidence today, enough evidence which suggests that there is a reduction in diabetes and a better control of blood sugars for women who are hormone users. Okay, you mentioned GLP-1 agonists, and I'm just going to, you can tell us some commonly used names so that the audience is aware of what we're talking about. But it's now become one of those things where patients or women are demanding. And sometimes you feel, am I being the judge of whether to prescribe or not? And am I in a position to judge? But at the same time, it can be an escape route as well, because humans are in general, we want to save energy on movement and eat what we want, etc. What would be a good reason for someone to consider GLP-1 agonists?
Yeah, I've used them. I use them sparingly. When I do use them, it's always packaged with a lifestyle first approach. So I would not use it if someone were to meet me for the first time and say, I want this medicine, I'm desperate, I've tried everything, just give it to me. I would withhold the prescription because I need to know what's going on in this person's life. I need to know what else have they tried. I need to go deep into why did the previous attempts fail? Because again, I'm trying to get to the root of the problem. Because otherwise, the prescription is supposed to be for life, that if you stop the drug, the weight comes back. But we don't have data on this. And as much as I am qualified to prescribe the drug, I'm also putting my degree on the line, exposing you to a lifetime of risk that I don't know is okay. I don't know it's acceptable. I don't know what will happen if you stay on it for 10 years. We just don't have that data, human data. So what if I never see you again? And what if you just end up staying on it, right? In India, also, the medicines are not so well regulated. So it's very likely that you just get the medicine and then the doctor and patient, who knows if they meet again. So I don't like that context. I have used it in specific situations, like, for example, and I know your audience is female, but this could go for either gender. Someone was overwhelmed with so many things happening in life, already working with me on all the four wheels of the lifestyle car, was totally like, feeling like it's slipping away. They're not able to stay focused. The glucose levels are rising. So we used it there. Another patient had a attack of sciatica where they were fully bedbound. Glucose levels were rising. It's like you're feeling helpless laying there in the bed while you're in bed rest. And I worry because what do GLP-1s do? They can expose you to muscle loss. Muscle loss is the worst retirement plan ever. Right? If we're talking about perimenopause, menopause, we're talking about planning for how will I be when I'm 60 and 70. Muscle loss is not going to help you when you're 60 and 70. You need to be gaining muscle for those years. So GLP-1s are not helping us with our long-term plan of staying agile, fit, strong muscles, strong bone. So I prescribe it in the context of we're doing this short term. Let's have some sort of contract between each other. The goal is to get you off this soon, right? I'm not comfortable giving it to you for the rest of your life. Usually, because my relationship with the patient is such, that's how we end up going forward. But I wouldn't just give it as I'm not here to judge somebody, but I want to feel good about what I'm writing on paper, that I've done right by you. And so that's why I make sure we do it with this protocol.
Yeah. And again, I think that whole weight loss, getting so obsessed with that number on the scale that we are willing to let go of muscle in the bargain. That is very often we're not thinking of being 70, being that 80-year-old woman who's not frail. And frailty sounds so scary. It just sounds so scary.
It does. Sorry to interrupt. And so what I do is, though, except for the person who is stuck with sciatica, what I do is I ensure that the protein is up to target and that we're doing the strength training. So I actually have my patients send me their workout clips, like not the entire session, but little clips so that I can eyeball it and say, hey, this, you haven't actually pushed your muscle. I'm looking for hypertrophy focused workout, muscle gains, not just endurance, like low weight, low and high reps of like 25 reps of a very light weight, and you could just go on all day. That's not really likely to cause much hypertrophy. So I'm looking at super slow workouts, more time under tension, a heavier but slower repetition where you actually reach technical failure, where the dumbbell or the weight does not complete that last repetition. And I want to eyeball that and give them feedback so that we're investing in muscle while we're on the GLP.
Right. Yeah. Challenging ourselves is a tough one in all aspects. We don't like to do it, but the thing is that the visual changes take a while to be there, right? So like if I'm exercising today, I'm not equating it to my muscle mass or the way I'm going to look in a pair of jeans after 6 months, that's a difficult one. So I'm glad that because that one-on-one involvement is so important in getting through to that woman over there.
Yes.
So yeah,
it's good. I want to add something there about I've been in this lifestyle change space for so long that I've gotten deep into even just the workings of the human mind in terms of habit change. So like books like Atomic Habits or coaching techniques like motivational interviewing, where we need to understand, or even this amazing book called Switch, which is about how changing habits is hard. And what they say is we're always wired for instant gratification. So the gym is going to give me those shapely biceps maybe 3 years from now. So how do I keep showing up in the darkness when there's no fame, there's no good selfie, there's nothing going on, and it's just drudgery and pain, right? And what is the short-term reward you could give yourself for having showed up? Bring up the short-term rewards of something that's not going to give you results till the long term. And also listen to your self-talk. Like, what are you saying to yourself when you show up in the gym? If you say, it's so cold, it's so painful, I don't like this, it's not working, I don't like what I see in the mirror, terrible one to motivate yourself to show up again, right? Or I don't like what the weighing scale said to me this morning. That's not a feel-good feeling, and we're going to eventually run away from that. Versus what's my self-talk and my narrative that helps me stay consistent. So my own fitness transformation happened when I realized I was a sedentary doctor. I just used to study my books, and then all I did was just give exams. I didn't know about exercise. That's for other people. I don't have time, right? And then kids, and so I was like, I'm a busy doctor, I'm a busy mother, I have all the reasons to not exercise. And I was going through a mindfulness training. I trained in mindful eating to work with people of emotional eating and binge eating conditions. So during that mindfulness process, I was learning. They were teaching us to think of self-talk, and I was like, oh, I'm saying a self-limiting statement. I'm saying I'm too busy for workout because of kids and office. And how can I change that where I'm empowering myself? So I just replaced the but with and. So I said, I am a fit doctor and mother in the present tense. And just by changing the self-talk, my whole relationship with fitness changed. And James Clear in Atomic Habits will say that a smoker might say to you, no thanks, I'm trying to quit, which means I'm still a smoker. Or you could say, no thanks, I'm not a smoker.
Yeah, makes sense. I think that's absolutely, that's a brilliant thing to bring out, because ultimately, there is implementation failure at so many levels. We all understand what the gym can do for us. We all know eating that candy or that samosa or those fries isn't good for us, but we still do it. Yeah. And of course, it is what we're saying to ourselves that finally decides what goes into our mouth or where we show at the gym. And discipline is boring. It is boring showing up is boring, but it's the only thing that works. And so if you don't talk to yourself about it, like for me, every gym session that I do not show up for is like, the only thing I have to tell myself is, by going today, you are going to prevent yourself from falling down, or
Right.
you are not going to fracture yourself. Like that is literally the sentence to me every time that I do not feel like going to the gym is, you know what, if you go today, you'll probably reduce, you will reduce your risk of fracture. So I think that each one of us has a fear, and and it can be overcome. That's the important part. Right?
Exactly. Yeah. And I start with that, right? And I'm hearing what you're saying. If I may, if you give me permission, I just want to use that, what you just said, right? And you're disciplined enough, right? You're a strong, you know how to put your mouth there and follow up and do it, right? And so many people struggle with this. So what I ask them to do is, and there is something built into what you're saying, which is self-love, right? I love myself enough to not give myself that fracture in my 70s. That's why you're working on it now, right? So without realizing it, you're actually showing up every day because of self-love. More than fear also, actually.
That's true. That is true. I never thought about it that way, but you're absolutely right. But yeah. And I feel like that is such a motivation. I feel the other thing that really works with women especially is telling them how it will help their children.
Yeah. It's a big part of your identity.
Exactly. Yeah. Just the thought that if something were to happen to me, it would be so limiting for my children, because now they will have to drop wherever they are and come and look after me. I think that sometimes works, but again, that's fear-based. But you're right. It all starts with
yes.
with love itself.
So I ask people. So the motivational interviewing coaching technique that I've learned helps me do this, which is if I start with the assumption that everybody wants to thrive, even the person who's eating junk all day, not exercising, doing everything that doctors would cringe at, okay, even they want to thrive. So if I start from there, I need to ask them, what matters to you? What would life look like if you could get those health goals that matter to you? What would that? I'm just wondering, can you walk me through that? And then they'll say things they care about, and their eyes will go up. Like when they start visualizing positive things, something just makes their mind expand a little bit, and they're not feeling shameful, because what they're expecting from this healthcare visit is to be shamed, is you're doing it all wrong. Don't you know you're going to go blind if you do this? And what's wrong with you? You've gained weight. I told you to lose weight. All this scolding that comes with unfortunately normal visits, right? We need to stop doing that. And we need to connect with these humans that are in front of us who want to thrive. Can you please share your goals with me? Yeah. I would be so honored if you could share what matters to you. Well, I want to travel. I want to be there for my kids. I want to be there for my grandkids. I want to, be a leader in my Rotary Club. I want to garden. They have dreams. And when you show them, okay, so you have this emotional eating that happens tonight because you're sad, lonely, upset, angry, etc. And you want to be fit to garden and travel and see the world. And both of these are you. You have both needs. You have these immediate needs of, I need relief from this bad emotional problem, so I'm eating something for immediate relief, dopamine, pleasure, whatever. And I have these long-term goals, and that both of those are me. And if I could just respectfully give that to the patient or client and just give space, stuff starts to move, because they're like, oh yeah, these are both me. And they've never heard their own story given back to them in that neutral, non-judgmental way. And their wisdom will start, their shift gears starts, because you've created a safe space where you didn't judge them.
That is beautiful. I think that is so beautiful. That's a wonderful, powerful tool to visualize yourself as these two things, and then actually see that, hey, they're pretty antagonistic right now.
Yeah.
Action versus goal, they're not really aligned.
Exactly.
But that's a beautiful tool. I think all of us should learn to use.
Yeah.
It. So thank you for sharing that.
Sure, I'm happy to. And that's probably at the core of every yo-yo diet or every I fell off track situation, or I fell off the wagon. I'm like, where's the wagon? It's all in our head, right? So when we hear our self-talk, we'll realize, where are my two needs that are clashing, and I'm not taking care of both, and I'm denying both parts of me.
Yeah. Makes sense. That is wonderful. Okay, I think we've been chatting for a while now, and I think we can go on for many hours. But let's just let's hear 3 actionable tips for our women here. They're going through perimenopause and menopause. They have a higher chance of getting diabetic. Some are pre-diabetic. Some are already diabetic. 3 messages for them to help their metabolic health today.
Okay. Assuming nobody right now that is listening has any kind of kidney disease, I am recommending 1.2 grams of protein per kg body weight per day, which means roughly you're looking at, for a 70 kg person, about 1.2 into that would be about 85 to 90 grams of protein a day. So you're looking at 25 to 30 grams of protein at breakfast, lunch, and dinner. Start reading the labels to know if you're getting that much protein. Most women that I see, at least, are not. They're not getting it as a default, especially if you're a vegetarian predominant person. Very difficult to get it unless you're really counting. So start counting your protein. That's ask number 1, because you're heading into that phase of life where your protein requirements go up, even though your efficiency of use and putting into bone and muscle is going down. Second is carbohydrates, because we're on the verge of getting that insulin resistance, that belly fat, that difficulty moving glucose through the system, reducing your carbohydrates. And why do I ask you to take more protein first? Is otherwise you'll be like, but you're taking away my main thing that I eat. I'm having FOMO about this. Like, I'm getting panicky that you're taking my main food away. So I'm first telling you to eat more, right? And you'll feel full. So if you're full, it'll be easier for you to let go or reduce something else that you were eating. Right. And this second or the third one, so first is really get your protein up. Second is reduce your carbs. The third one is kind of like this all-encompassing piece, which is, what's that self-care thing? You know, what's that self-love thing that would make it worthwhile for you to invest in yourself? Like we've been talking through this chat, is what motivates you? What matters to you? Where do you want to be in 15 years, 20 years from now? Why would you get up and change your habits? I mean, there are, I'm not going to say shortcuts, but there are things being marketed to us, whether it's that snack, or whether it's that addictive screen time, or it is that prescription drug to numb the symptoms. And it's okay to use those as temporary relief, but is that who you are at the level of identity? So can you listen to your self-talk? Who are you? Where do you want to go? What matters to you? Get in touch with yourself. It's a beautiful phase, perimenopause, menopause. You're shifting gear in life. It's a phase of change. You could change in many ways.
Yeah. No, that's, I think, like, sometimes it's a wake-up call for us, and I feel like alarm bells are ringing, and it's the perfect time to pivot and say, hey, you know, I need to look after myself. It's going to be a beautiful beyond. Let me just work towards it. So, but getting the right support at that time, I think, is so important. That's the, that a lot of women don't get it, and it becomes a very negative phase, and we can make it more positive by just educating ourselves, right? Yeah. Uh-huh. So yes, so thank you so much for this. This has been just wonderful. Lots of things to take away, including not just nutrition and sleep and all the other tips that you've shared, but things about being mindful and helping us change our habits. So I think that's something we don't hear from doctors very often. So thank you for sharing all of that with us today. And I am really looking forward to this course that you have to share. Coming up next month. So it would be wonderful whenever you share it. We'll be definitely having a look at it. So thank you again.
Thank you. Thanks for having me, and thanks for what you're doing for the community.
Thanks again for tuning in to MenopauseWize. Stay informed, stay empowered, and I'll see you in the next episode as we continue to navigate the menopause journey together. If you're a healthcare provider interested in collaborating with us or have insights to share, we'd love to hear from you. Please email us at info@menopausewize.com. That's wise with a Z. And before we go, a quick medical disclaimer. The information provided in this podcast is for educational and informational purposes only and is not intended as medical advice. Always consult your physician or a qualified healthcare provider before making any decisions regarding your health or any medical treatments discussed in this podcast. While we strive to provide accurate and up-to-date information, this podcast does not replace professional medical consultation, diagnosis, or treatment. If you have any concerns or symptoms that require medical attention, please seek advice from your healthcare provider.